aimed mostly to achieve this goal and solving problems of difficult intubation and prevent failed intubation. To achieve this goal, it would be necessary to demonstrate stages of correct intubation technique step by step, since incorrect techniques are major and frequent causes of difficulty. So this demonstration is divided into number 1, technique of intubation, number 2, difficult intubation. The first part would benefit medical students and junior residents. It also provides a review and re-education for those who have developed bad habits. The second part, difficult intubation, would deal with 1, signs and symptoms to help for pre-op evaluation, 2, causes and diseases which cause difficulty, 3, techniques which may solve the problems, 4, fiber optic intubation, and 5th, complications. First, technique of intubation. We describe the procedure which is applied to intubation during induction of anesthesia. The technique for other circumstances would require some modification of this. First, we'll proceed with oral intubation, followed by nasal intubation. Oral intubation. Equipment should be checked before intubation is attempted. The rim of the mask must be quite inflated. If it is deflated like this, it will not prevent the leak when you place it over the face. The rim of the mask can be inflated. If it is not adequately inflated, just simply by taking a syringe and put it at the one-way valve here and inflate it more so that leaks would be prevented and ventilation can be achieved satisfactorily. Head strap also would help to prevent leak. It should be placed on these hooks here. And the tracheal tube must be appropriate size. Average adult ladies require between 7 to 8, and average adult men, they require between 8 and 9. The stylet should be appropriately placed inside in the tracheal tube. The tip should not be projected like this because it can cause esophageal rupture. We should pull it back carefully so that the tip of a stylet be proximal about 1 centimeter to end of in the tracheal tube. And this side is bent forward about 90-degree angle, so it would prevent from accidental pushing stylet. This portion of the stylet should be curved like this, not all along the endotracheal tube. It's wrong to be this way. It should be curved like this. And the cuff should be inflated. If it is not inflated, we test it, make sure it doesn't have any slow leak, and then we deflate it again. We may lubricate it with some xylocaine jelly. Anesthesia machine should be checked. The cylinders should be checked to make sure that there is enough oxygen in it. Then we need to make sure that there is no leak in the machine by flushing the bag, inflating the bag, and the pressure here should be stable. It should not drop. Drugs should be checked. Curare is prepared 3 milligram per cc. 1 to 1.5 cc is usually used. Thiopental is prepared 2.5% or 25 milligram per cc. Sectional choline is prepared 20 milligrams per cc, but 5 to 10 cc is prepared. Lidocaine is usually given to prevent reflex hypertension. Other muscle relaxants like Norcron or atracurium or pancuronium are prepared. Oral airway, nasal airway, tongue blade, endotracheal tube with jelly, atropine, other vasopressors like ephedrine prepared 10 milligram per cc or norepinephrine 100 microgram per cc. Laryngoscope is checked to make sure that the light is functioning. Curved blade, straight blade are to be ready. A few words about airway. First of all, the face of the patient should be at the level of the xiphoid process of anesthetist. The neck should be flexed between the trunk and the neck and should be extended at the junction of atlanto-occipital joint. If this doesn't show a good airway, we may need to remove a pillow, or in the operating room we may have to adjust the head of the table, which has a hook here, that by releasing the hook we can bring the head up and down and keep it in an appropriate position. For oral intubation during induction of anesthesia, patient needs to be oxygenated with 100% oxygen by placing the mask over the face. The mask covers the nose and the mouth, and the flow rate of oxygen must be more than minute volume of the patient. Minute volume of average patient is 6 liters per minute, so minute flow rate should be between 8 to 10 liters per minute. If thiopental is to be used, a test dose, which would be 50 milligram 2 cc, is injected intravenously. The advantage of test dose is to check sensitivity of the patient and to make sure that there is no infiltration intravenously, and make sure there is no intra-arterial injection, although it is rare, but if it occurs, complication is very severe. Anaphylactic shock cannot be forgotten. 1 minute after the test dose, blood pressure must be checked to make sure that the patient has not changed his blood pressure much. And then respiratory depression is evaluated by asking the patient to take a deep breath. Please take a deep breath, sir. In and out. Okay, the patient responds, so that means still he's light. If patient does not respond, he may not need a large dose to put him asleep. After this, defasciculating dose of curare is given. Usually 3 to 4 milligram of curare is given before sectional choline is given, and this would decrease fasciculation by sectional choline. While oxygenation is continued, lidocaine is given 1 milligram per kilo body weight. And fentanyl may or may not be given. In geriatrics, has been shown that giving fentanyl between 50 to 150 micrograms decreases the chances of reflex hypertension. Ventilation is continued, and then sleeping dose of thiopental is given between 3 to 5 milligrams of thiopental is administered. We will wait 30 to 40 seconds. In geriatric patients that they have a slower circulation time, it may be needed to wait longer than 30-40 seconds. And after this time interval, you ask the patient to take deep breaths. Please take deep breaths. Patient doesn't respond, so that means he's asleep. Then we check the lash reflex. Although the patient is asleep, but he may be still light, we might need to supplement it with another 50 to 100 milligram more of thiopental. Now we check again to make sure that the lash reflex is negative. Then we continue ventilation and make sure that the patient can be ventilated. Sexencholine is injected 1 to 1.5 milligram per kilo body weight. We would wait 30 to 40 seconds and then try to start intubation. And during this time, we keep ventilating the patient, and actually we should hyperventilate the patient. Laryngoscope should be held with these 3 fingers. It should not be held with the whole palm. That would stimulate even experienced anesthesiologists to put force and anchor over the upper teeth. It should be held like this. We take the mask off. To open the mouth, we should open the mouth with these 2 fingers, the long finger to the upper teeth, the thumb to the lower teeth. In order to remind you not to forget about that, we use these 2 fingers to snap. So the long finger goes to the upper teeth and thumb would go to the lower teeth, and we open the mouth as wide as we can. We hold the laryngoscope like this. We start from the right side of the mouth and advance laryngoscope all the way down toward the esophagus. At this time, we don't try to look. We just try to keep the mouth open and advance laryngoscope as far as it goes. And when the laryngoscope is too far down, then the right hand becomes free and comes here, and we extend the neck as much as we can. Now we try to look. To show you in a more detailed and for ethical views, I would like to show you these parts in slow motion in a mannequin. To keep the mouth open, we should leave the long finger on the upper teeth and thumb to lower teeth and trying to open the mouth like this. If you try to open the mouth this way, we require a large amount of pressure, and we cannot keep the mouth open, especially in awake patient. If awake intubation is planned and you are fighting with the patient, patient is fighting with you, it's very hard to keep the mouth open. But this way, it is easier to keep the mouth open. When the mouth is kept open, Laryngoscope should be introduced from the right side of the mouth, pushing the tongue all the way toward the left, not from the center, not from the left. It should be placed to the right side of the mouth, trying to push the tongue all the way toward the left. At this point, you should try only to focus your attention to push the laryngoscope down, and at this point you don't look for the larynx. At this point, when laryngoscope is far down enough, the right hand is free because the mouth now is kept open by laryngoscope blade, and right hand comes up here and makes the neck well extended as much as we can. When the larynx is exposed, and the tracheal tube should be introduced from the right corner of the mouth, keeping the concave shape of endotracheal tube to the right and introducing the tube down. If you hold the tube this way, it will obstruct the view, and that's wrong. When the laryngoscope is advanced far down, it will go into esophagus. Now, that's the point we start looking. At this point, we just see a tubing, which is esophagus. We start pulling the laryngoscope back until it gets to the level of the epiglottis. At this point, epiglottis will fall down in front of the view. To get the view of vocal cords, we re-advance the curved blade down to the base of epiglottis, between the epiglottis and the tongue, and pull it up this way. The view of glottis would become patent. If it is straight blade, the straight blade goes in the front side of the epiglottis and lifts the epiglottis up, and we can see the vocal cords. If still the glottis view is not seen, the operator will ask an assistant to push his hand over the larynx and have him move the finger of the assistant, and the fingers of the assistant should be on the cricoid cartilage, and whenever he gets a good view, then he asks him to hold his hand there. If he wants to hold his hand and then ask the operator to push his hand, it doesn't work. The operator's hand has to be placed over the assistant hands and then move it where the good position is obtained. Then he asks the assistant to hold his fingers right there over the cricoid cartilage, and then he would try intubation. When the glottic view is shown, and then the tube is passed into the glottic between the vocal cords, and it should be advanced until the cuff, proximal portion of the cuff, is about 1 to 1.5 centimeter below the vocal cords. When the glottic view is seen, the stylet is held stable, and the endotracheal tube is kind of pushed down. So the stylet is not pushed in with the laryngoscope into the larynx. This way, trauma to mucosa of the larynx is prevented. In case of pediatric endotracheal tube, it should be advanced up to the second mark to level of vocal cords. After the tube is in, then we pull the laryngoscope out, put it on the side. At this point, these fingers should be to the tube and 1 or 2 fingers to the upper jaw, so the tube would not move in or out. Then we connect either the ambu bag or the anesthesia machine. At this time, we need to inflate the cuff so there wouldn't be any leak. Then we ventilate rather vigorously to compensate for the period that we were not ventilating the patient. The level of the teeth at this point should be at the level of 22 in most patients. If mass spectrometer is available, instead of observing the movement of the chest, you may want to check the carbon dioxide on mass spectrometer. And after you make sure that you are ventilating the chest, then you may put the ambu bag or anesthesia machine down and attach a tape and make sure that the tube is fixed in this position. Another method to check the position of the cuff is to inflate and deflate the cuff. Then you can put your fingers over the larynx. Most of the time you can feel where the cuff is and you can assure the position of the tube is appropriate. After the position of endotracheal tube is secured, we should check for the amount of pressure inside the cuff, first by inflating and deflating the cuff and feeling with the finger, and next we can look at the pressure gauge, keep the hand over anesthesia bag and inflate it until the pressure of 30 is seen, and listen to the leak. You keep your ears close to the mouth and hear the leak pressure. When it goes higher than 30 to like 35, you should hear very small leak. And after you make sure that there's no leak, you should listen to the chest and make sure that breath sound is heard both sides, the left and the right. And the tracheal tube can go into the right most of the time. After about 20 to 30 minutes, if nitrous oxide has been used, we need to double check the pressure of the cuff, because this gas is absorbed through the cuff and increases the pressure. So we double check to make sure that the pressure is not more than 30 centimeters of water. I thank you very much for watching this video. I hope this has helped everybody. Now I'm going to describe to you and demonstrate some of the techniques